First, I'll entertain a motion to waive the quorum requirement. Do I have one? I've got a motion here. Got a second right there. All in favor say aye. Motion carries. And then now I'll entertain a motion to approve the April 25th, 2025 meeting minutes. Get it out in a minute. Got another motion. Got a second. All in favor? All right. We got the housekeeping finished up there. Thank you all so much. We've got a little bit, since the Cubs are playing at home today, got a little bit of a curveball, and you've seen in our schedule. And so we're going to start off the agenda this afternoon and continuing the discussion of potential consideration of the resolution regarding audiology services. A resolution I'm sponsoring alongside my good friend and colleague, Kentucky Representative Deanna Frazier Gordon. Representative Gordon raised this issue at our November meeting, and we will first consider a draft resolution at the spring meeting in Charleston. Since we have heard no opposition to this resolution, and since it's very straightforward, we would likely vote on it today. You can view the resolution on the app and website and in your binders on page 88. But before we go there, I'll recognize Representative Gordon for her remarks. The floor is yours.
Thank you, Mr. Chairman. Is this on?
Yeah, a little tighter there.
All right. Thank you, Mr.
There you
Chairman. I was disappointed that I wasn't able to join you in Charleston. Delta decided that they needed to do some work on the wheel, so I'm glad to be able to be here today. So as Chairman Pollock mentioned, I sponsored a bill on this issue in Kentucky last year, and it deals with changing state law in light of recent regulatory change from the U.S. Food and Drug Administration regarding classification of both over-the-counter and non-over-the-counter hearing aids. So for background, in August 2022, FDA promulgated regulatory changes establishing over-the-counter hearing aids as a new category of medical devices while classifying all non-over-the-counter hearing aids as prescription medical devices. These changes took effect on October 17th of 2022. That classification has resulted in confusion among practitioners and policymakers at the state level as why the change in law is necessary to clarify things. And I'm an audiologist by trade, so I can speak firsthand as to the confusion that this has generated. It's pretty simple, straightforward issue. There's no change in who's providing the service or how it's being delivered. It's just because they added that new classification, we just needed to make that more known. So thank you, Mr. Chair.
Thank you, Representative Gordon. Appreciate those comments. Now we'll hear from Julian Roberts of the American Association of Payers, Administrators, and Networks. Julian, you may begin.
Thank you very much, Mr. Chairman, and thank you and the rest of the committee members for allowing me the opportunity to speak with you today. My name is Julian Roberts. I am President and CEO of the American Association of Payers, Administrators, and Networks, as well as a subsidiary, the Hearing Network Alliance. And we strongly support this bill, this resolution that's before you, and want to thank Representative Gordon for sponsoring it. I will not get into the details. I believe Representative Gordon provided the details of the resolution, pretty straightforward. But the FDA did come out and make it clear that their intentions were not to disrupt the current process of prescribing hearing aids in this matter, and stated that those that were previously prescribing hearing aids should continue to do so. I will mention that this has been addressed in 22 states, and this is one issue where the audiology community, the hearing instrument specialist community, and the payer and network community have all actually worked together to ensure that this is corrected in the various states as we move forward. Not often that you get payer and provider agreeing on the same thing and supporting it and fighting for it jointly. So today I urge you to support the resolution to affirm the authority of the hearing instrument specialist to continue to provide care, prevent coverage disruptions, and protect access to those who most need it. I'm happy to answer any questions.
Thank you, Julian. I'll now open up the conversation for any questions with our legislators here today. Any questions whatsoever? It's pretty simple, pretty straightforward. Any questions? Okay, thanks for everyone. Representative Gordon, Julian, for those comments. If there's not, hearing no further questions or comments, I'll entertain a motion to adopt the resolution. And so moved. I hear a motion over here. I got a second right there. All in favor of this resolution, please say aye. And looks like your resolution is approved. And that will now be placed on the Executive Committee's agenda for final ratification.
Thank you, members and Chairman.
Representative Gordon, do you have anything else you want to bring to the committee today?
I do. I have an announcement. Thank you. I appreciate the opportunity again to be with here, and I want to let the committee know that I will be introducing a model act for consideration to address the many issues of patient access and preserve the quality of care between an optometrist and their patients. This issue has arisen because of the third-party payers and how it relates to the consequences from vertical integration in that relationship.
Okay, all righty. Thank you very much. Interesting there, and I look forward to having those conversations. Obviously, we will get into that here in Atlanta and see where this goes. Thank you so much.
Thank you.
Next up is a discussion on the proposed amendments to the NCOIL Dental Benefits Contracting Model Act. You can view this model in your binders on page 91 and on the website and the apps. We had a good discussion on some proposed amendments to this model at our last meeting in April. And since that time, I know that the interested parties have been making progress on certain items with the sponsor. And before we go any further, I'll turn things over to the sponsor, Vice Chair of the committee, Arkansas Senator Justin Boyd. Senator Boyd, there he is. Welcome.
Thank you, Mr. Chairman. I was sorry to have missed the April meeting, but I'm glad to be back with everyone today. As you noted, Mr. Chairman, I have been discussing these amendments with the interested parties since April, and I'm encouraged by where things are going. In the spirit of compromise, what I've agreed to do is withdraw the proposed amendments that you see as new sections D and E regarding assignment of benefits and post-payment recovery, with the understanding that both sides will work towards trying to reach an agreement on the remaining proposed amendments. And because both sides are still engaged in a conversation, I'm asking, Mr. Chairman, that we not have a vote on the amendments today and we re-adopt the model in its original form until our next meeting in November while the interested parties continue to discuss things. This is essentially the process that the committee followed at our last meeting in April. I also think it might benefit everyone to have an interim meeting of the committee in September to keep these conversations going. I appreciate the input that everybody's provided so far, and I look forward to continuing to work with everybody. Again, thank you, Mr. Chairman.
Thank you, Senator Boyd. Appreciate that so much and the direction you want to see this to go. We'll now hear from the interested parties on this, and we'll begin with Chad Olson of the American Dental Association.
Thank you so much. Good afternoon, Representative Pollock, Senator Boyd, and members of the committee. I'm very grateful for the opportunity to talk about the amendments to the 2020 Transparency in Dental Contracting Model Act being offered by Senator Boyd and Assemblyman Gandolfo. These amendments are timely, necessary, and will truly make a difference to providers and the patients they serve. I would like to focus the majority of my comments on the positive benefits of shifting the model language to opt-in versus opt-out for both network leasing and virtual credit card, because I know that issue is causing the most consternation with the payer community. To do so, I'd like to take a step back and humanize the process that providers and patients experience in the current environment. One of the most annoying and in some cases troubling trends in modern life is how often we are automatically enrolled in various programs and our information is shared with third parties, and then we must proactively contact the company to hopefully, and I say hopefully, remove ourselves from a barrage of unwanted communication. We've all said it, #unsubscribe. So take leasing. Traditionally, dental insurance carriers set up their own provider networks and were responsible for their maintenance. In turn, dentists, many of whom are small business owners, carefully evaluated operational expenses and their pool of patients when considering whether to join a network. It is a delicate balance, understanding overhead and how many in the patient pool are in network, meaning the office must receive a reduced fee. Flash forward to today, and the traditional network model has morphed considerably. Dental insurance carriers lease networks to each other and include clauses in their standard take-it-or-leave-it contracts with providers that allow the insurers to lease the network relationships. The result has been less accountability and transparency for providers and patients alike. So in response, NCOIL saw value in promoting the establishment of transparency in network leasing by adopting the Model Act in 2020, but issues remain. The amendments proposed by Senator Boyd and Assemblyman Gandolfo would create a contractual process more attuned to the typical contract process. Think about how few contracts are designed with auto acceptance and require the signatory to opt out. But that is how the insurers are currently operating. It should be that a contract is an offer that requires consideration and acceptance, not capture and fight for escape. Changing to opt-in aligns contracting procedures accordingly. So think about it like this. Isn't it nicer, and don't you feel like you're more in control of your data if you have the ability to check the box to subscribe to offers from a company, rather than finding out that you forgot to unselect a box and now you are stuck with offers you never wanted? For a dentist to find out that your office received a form email from the insurer that your network relationship was leased and no one opted out of it, and this now means that 20% of your patient base is suddenly receiving a deeper discount, well, put plainly, this is more than just an annoyance. It could be an existential threat. Similarly with virtual credit cards. Remember, the dental office has to pay a fee to receive the money it is owed if the dentist is automatically enrolled in a virtual credit card or some other form of payment that requires a fee. Again, it is empowering to be informed of the option to choose a virtual credit card and then choose it if it works for the practice. Further, if an opt-in approach is adopted, there are benefits to patients and, in our view, benefits to the insurers who aren't kept in suspense about whether a dentist will opt out. Insurers will know immediately whether their contracted dentist is in or out of the new leased network and can plan accordingly. With opt-in, patients will be able to make decisions based on network status more efficiently. I would like to quickly address some of the chief concerns brought forward by the insurers in their letter opposing the amendments. The insurer's overarching claim is that there isn't a policy rationale for the amendments. For those of you who want to keep dentists practicing in your rural districts, or others of you who want to ensure your constituents in an urban environment have access to a dental provider whose practice remains a viable and vibrant part of your community, I have no doubt the policy rationale is clear. The truth is, the chief value carriers offer to employers, which are the insurer's true customers at the end of the day, is the network discount they offer. But the key to understanding where we're at now is these networks are no longer homegrown. Instead, networks are pieced together to form an increasingly Byzantine system that confuses both providers and patients. One dentist, a doctor I know from New Jersey, had signed onto a small network in the 1990s, yes, eons ago, when Nirvana was still on the radio, as a favor to a single patient. Flash forward to the current day, and that network relationship was sold to a large carrier. The dentist only found out about the change because his patients started saying, it's so great that you're in network. The effort to extricate himself cost him tens of thousands of dollars and negatively impacted his relationships with his patients, who were, of course, confused. Finally, I'd like to state clearly that the ADA is not against robust networks, and we are not against virtual credit cards or other innovative forms of payment. Not at all. Instead, we are for transparency, which means full knowledge of how business relationships may be shifting and empowerment to proactively make choices that will keep providers doing what they do best, providing care to patients. I think we can all opt in to that. I urge the committee to adopt the amendments and look forward to questions and working with the payers on further progress on this. Thank you.
Thank you, Chad. Let's now hear from Bianca Balali of the National Association of Dental Plans. Bianca, the floor is yours.
Thank you so much. Can you hear me okay?
Yes.
All right. Thank you, Chairman Pollock and members of the committee. It's a pleasure to be before you today to talk about this. My name is Bianca Bilali. I'm the Director of Government Relations at the National Association of Dental Plans. Our members provide dental plans to more than 200 million Americans nationwide. I'd first like to commend the work the committee has done to protect consumers and support a sustainable dental benefits market. Your thoughtful development of this model in 2020 with extensive stakeholder collaboration represents strong public policy. Just this session alone, we saw an additional 3 states adopt aligning provisions with the network leasing provisions in this model, raising that count to 18, and another 4 that adopted the virtual credit cards provisions, bringing that count to 15 states. The proposed amendments represent a sweeping overhaul of this broadly adopted policy framework. One of the central proposed changes that's been referenced related to network leasing would shift the model from the opt-out to the opt-in, which would have a significant impact on consumers and market stability. An opt-in framework would undermine the workability in networks, which would result in higher costs for consumers, as disrupting networks jeopardizes discounts and other consumer benefits and protections that these networks offer. Consumers would face surprise billing, as the risk for unknowingly seeking care from out-of-network providers would increase substantially, and providers would face additional workload to confirm network participation and reimbursement. Consumers would see reduced access to quality care due to the likely reduction of the number of providers within their networks. Similarly, the proposed amendments shift the virtual credit card and EFT provisions from opt-out to opt-in as referenced. Currently, the model ensures that alternative payment methods are offered to providers beyond credit cards, that providers are notified of changes to reimbursement methods, and that plans provide clear instructions for selecting alternative payment methods. Fees are disclosed to providers, and shifting the model from an opt-out to an opt-in creates substantial risk, including a potentially complex implementation process, as payment elections vary by plan and timing, making compliance confusing and inconsistent. Providers could also see payment delays, as it is unclear what would occur without an opt-in election of payment. These changes could also result in provider dissatisfaction, as we know providers like the ability to obtain quick, secure payments through their existing credit card terminals. Additionally, the proposed amendments eliminate the ability to provide electronic notices in favor of paper. This reversal of modernization would result in slower communication and higher cost, which undermines progress towards secure electronic records and modern digital exchanges. In addition to these provisions, the proposed amendments would introduce both infeasible and impractical mandates that are not workable in practice. These include the disclosure of fees related to virtual credit cards and EFTs. These are fees that plans cannot track or control bank and payment processing fees. Requiring plans to provide notices when it is the vendor, not the plan, who manage payment processing and provider communications, as well as the expansion of affiliate requirements, which are already addressed in existing transparency affiliate disclosures within the model. For these reasons, we recommend the committee refrain from adopting the amendments as drafted and retain the current approach to network leasing, payment options, and electronic notification. Instead, we encourage a collaborative discussion on the policy to explore potential opportunities to improve the opt-out process. We urge you to avoid making these wholesale changes to the model and risk destabilizing a proven framework. We look forward to continued conversations and discussions surrounding this topic with the stakeholders, as well as the chair and sponsors of this model. And I want to thank you again for the opportunity to speak before you today, and would be happy to answer any questions.
Thank you, Bianca. Next up is Jill Rickard. Jill's with ACLI. Jill, the floor is yours.
Thank you so much, Mr. Chair, and thank you for squeezing me in. I know this is a packed agenda today, so I'll keep my comments brief. I am Jill Rickard, a Regional Vice President of State Relations for the American Council of Life Insurers. As you may know, many of our life insurer members offer dental insurance plans, and that is the reason that I am up here, just to lend support to our partners at the NADP. We also oppose the substantial amendments proposed by the ADA to this model, mostly because they would erode consumer protections. I will focus my comments on one section, which are the proposed amendments to the network leasing, which Chad also spoke about. It would change the opt-out framework to an opt-in. We have seen no compelling evidence to support this change to the existing model, which we believe strikes the right balance between transparency and provider choice. Providers choose to join dental networks because they offer significant benefits, not only to their offices, but to their consumers, and help them serve their patients better. The leasing process is transparent already. Providers receive 30 days advance notice before a new third-party leases a network, and the provider can choose to opt out if they do not wish to participate. However, very few providers do choose to opt out because the networks provide them such significant benefits. If the model were changed to require an opt-in, it would result in higher costs and decreased choice for consumers. Number one, the negotiated savings for consumers would be lost. Providers would also face increased administrative burdens if they have to take steps to opt into a network and confirm reimbursement terms. This would leave less time for patient care. And finally, the opt-in framework would reduce the number of providers to which a consumer has access. Not only is this problematic on its own, but as Bianca mentioned, if a provider fails to opt in and a consumer unknowingly receives care from an out-of-network provider, that could lead to surprise bills and higher out-of-pocket costs. ACLI believes the model is working well, strikes a good balance, protects consumers, and has been widely adopted in the states. We urge the committee, along with NADP, to retain the current model's approach to network leasing, as well as its current approach to payment methods and electronic communications. Thank you again for the opportunity.
Thank you, Jill, for your comments. At this time, I'll now open this up for questions from our legislators. Anyone on the committee? Go ahead.
Thank you, Mr. Chair. My question is for you, Chad, related to the opt-in to the lease versus opt-out. Have any states passed the opt-in, or is there any legislation pending in any of the states currently?
Yes, thank you for the question, Assemblyman Gandolfo. Yes, we saw in 2023 that the state of Oregon did a leasing, is a law that is opt-in. So that has already occurred, and we had a number of states this past year, including Missouri, that introduced bills. So this is an issue that the state legislatures are looking at, and one has already acted. Thank you.
Thank you.
Representative Alverson.
Thank you, Mr. Chairman. So really a comment and a question, and I want to say to my colleagues, thank you very much for bringing this issue and working on this. It's my own personal observation that I think that the virtual credit card system is an unbelievably deceptive trade practice. You're essentially agreeing to pay somebody $100 for a service, but then you're forcing them to accept the $100 via a mechanism that you get to claw back a percentage of that without them having the opportunity to dispute that. I think that's about as anti-American, anti-capitalist as it gets. But I think for my two friends with the health plans, I want to know, do you believe that a health plan has a fundamental right to access a provider's services at a prescribed rate that they never negotiated with that provider directly? And where does that come from if you do? Because I'm not aware that that exists in any other line of business anywhere in the world where you can take the fruits of somebody's labor at a price you never agreed upon yourself and purchase that from a third party. That's just blows me away. I'd love to hear you comment on that.
I definitely would probably like to clarify your question, because you're not referring to the fee schedules, I assume.
Now I'm talking about the leasing and the fact that you're selling a contracted rate to a third party that never negotiated that contracted rate. And it strikes me as odd that in a society where, there are all these different small businesses out there and folks are out there and, a service costs what it costs, and maybe you have a discount that you offer somebody, a friends and family, or whatever it is, that in healthcare, we have this scenario where folks feel like they have the ability to purchase a discount from some other party and utilize that discount without first getting permission from the provider who offered that discount to someone else to begin with. I mean, and Senator, I know this happens to you all the time as a pharmacist, all the time. And it just seems so fundamentally anti-competitive and just so draconian. And I'm curious if you really truly believe that a health plan has the ability to purchase a discount from another health plan without ever negotiating directly with the provider, and where do you think that entitlement comes from?
I think what I can share is, based on my comments, we do believe that the model has a level of transparency with the notices that are provided to the providers when a network is leased, and that would be happening. And they obviously have the opportunity to then opt out if they do not want that to happen. So I would just reiterate that.
Thank you, Mr. Chairman.
Representative Sutton.
Thank you, Mr. Chair. Chad, I just wanted to clarify in your testimony, you were talking about an anecdotal story about a fellow who found out he was in a network only because his patients were happy that he was in network, and then he wanted to get out of the network, and was. Did I understand it correctly that because that raised difficulty with the customers who were happy that he was in network, that was somehow someone else's fault? What was the point you were trying to make there? I'm sorry.
Yeah, absolutely. The point is, again, with the context that this is a small business who has to think about the entire pool that you have of customers. So that means that you're really evaluating every time you're going to do a new contract, evaluation of whether you're going to join a network. In this case, he had signed on to a network for a single customer years and years prior, okay? Had not really had any other patients ever go into, utilize that network. Years later, a large carrier purchased that relationship.
Right.
There was no, there was no notice. And if there was, it's one of those things where, and again, it's very, I think, again, appealing to the human part of everybody in this room. You get a flurry of emails, you get a flurry of mail communications. He did not opt out. So then, when you haven't opted out and you have a sizable chunk of your patient base that you can no longer afford to take that discount on, you have to pull out of that network relationship. And that's what he had to do. And again, going back to the request for the amendments and the rationale behind them, if it is a proactive, where the plan is then trying to solicit him to get whether he wants to opt in or not, that empowers the dentist to do that evaluation that's so necessary.
Excellent. Thank you very much for adding the rest of the color to that, because I had a tough time figuring out what you were getting at. Thank you.
Any other questions? Thank you so much. Senator Boyd, would you care to close this segment out right now with any comments?
Thank you, Mr. Chairman. I just want to say that I do appreciate everybody coming to the table. Fundamentally, I think that we all live in this busy world, and for somebody to just think, hey, it's fine, you have this, did they send it via mail? Did they send it, via snail mail? Did they send it via email? Who knows? Maybe they'll start texting us. But at some point in time in America, you should have the ability to choose something that could be detrimental to your practice or not. And so, again, I appreciate both sides coming to the table. I look forward to debating this, and I appreciate everybody's attention.
Thank you, Senator Boyd. And, you started this out, which basically, and I'm going to quote you here, both sides will work towards trying to reach an agreement on the remaining proposed amendments. And so obviously this conversation is going to continue. Committee, just letting you know, we're going to have an interim call on this. And those who want to be on this call is going to be getting down into where we can find some common ground here. Obviously, when we end up in Atlanta in the fall, in the winter, that we can really have some structure here on seeing where this is going. There's a lot of, I'll be honest with you, pardon me, but when you talk about opt-in and opt-out, in-network, out-network, there's a lot of terms that are kind of floating around out there. Everybody do their homework right now, because when we have this interim call, I really think as a committee and obviously interested parties involved here, we can just get to, again, that common ground. So thank you so much for this conversation. So at this point, we're just going to readopt the motion as is in Charleston to continue this on to Atlanta. Is that right? So do I entertain a motion to readopt this model? Senator Boyd has a motion, and I got a second right here. All in favor to readopt this model as is? Say aye. Okay, Jim.
Thank you.
Bianca. Jill, thank you. All righty, moving right along here. Next on our agenda, continued discussion on the NCOIL Prior Authorization Reform Model Act. Another interesting hot topic of discussion on a Friday afternoon. As a reminder, we first discussed this model law language at the Charleston meeting, and since then we have received a substantial amount of interested party comments on the model. Interesting. And we will hear in more detail a number of these comments today. You can view the model on the website and app and in your binders on page 73. We won't be taking any action on this today, just continuing our discussion. Before we go any further, I'll turn things over to the sponsor of the model, Mississippi Senator Walter Michel.
Thank you, Mr. Chairman. You're exactly right. It was a very interesting subject that we discussed at our meeting in Charleston. So interesting that time did not permit us to answer all the questions and listen to all the comments that individuals wanted to portray. We have received some additional comments through NCOIL, and they're posted on the website for anyone who may wish to look at those. Also, about a month ago, there's an announcement from the health insurance plans regarding a series of commitments to streamline prior authorization. With this in mind, Mr. Chairman, I look forward to the additional discussion that we're going to have from our panel today.
Absolutely. Thank you so much, Senator Michel, for bringing forward this important topic. We'll now hear from our speakers, and we'll start with Lucy Culp of the Leukemia Lymphoma Society. Is Miss Lucy? There she is. Floor is yours.
Thank you. Thank you for the opportunity. Can you all hear me okay?
A little closer.
How about now?
There you go.
Okay. So I'm Lucy Culp again with the Leukemia and Lymphoma Society. Thank you again for the opportunity to chat with you all today. If you're not familiar with us at LLS, we're the largest nonprofit dedicated to curing blood cancers and serving patients and their families who are impacted by those diseases. We work with patients on a daily basis to help them navigate, to get financial assistance, to navigate their health insurance plan, to find a provider, to get matched with a clinical trial. We even have a program that helps people navigate their medical debt. Right, cancers found in your blood and your bone marrow are incredibly complex to treat, and frankly, they're incredibly expensive. The average acute leukemia patient is going to look at about $500,000 in treatment just in cost just in the first year. So we're talking to folks when they're dealing with some of the scariest and stressful times of their lives for them and their loved ones. So I know this isn't the first time you all have been talking about this issue, and there's been extensive reporting, of course, over the last several years, but I do want to just shed a little light on why addressing prior authorization is so important for the folks that we serve. So at LLS, we partnered with researchers at Manat Health to really dig into this a little bit further, and they conducted qualitative interviews with 25 patients, right? Just talk to them about their experience. And what we found is that a patient's treatment journey really is inextricably linked with their coverage journey. You really can't separate the two. And what they found, too, is that the systems that we've we've built and implemented over time in this country to deal with really complex cancer don't map very well to the systems that we've created for insurance coverage, right? Networks don't necessarily match to where you need to go with a complex cancer diagnosis. And what the researchers really found that prior authorization and denials and kind of that denial navigation, the appeals process, that was one of the top challenges of the many challenges that folks face. That was one of the top things they heard from people. And we even see it anecdotally at LLS when we kind of ask questions out to our network and say, hey, have you had an issue paying a bill? Have you had an issue having a prior authorization get denied? It is one of the top things we hear from patients where they're facing challenges getting their treatment. Just one example, we were contacted by a patient recently whose treatment plan included receiving chemo 12 times, and rather than review and improve that entire course of treatment, her plan wanted to require prior auth for every single chemo visit. So you can imagine, right, just the stress and anxiety that she was feeling when she called us, trying to figure out should she even start treatment because at any time she might be told she had to stop. So just really, again, I wanted to make sure you all kind of understood the challenges that the folks that we serve face. And with that in mind, again, thank you for taking up this issue. We're really grateful that you're recognizing these challenges. I think the draft's purpose statement even kind of speaks to something we hear a lot, which is this involvement of a third party between patients and their providers. And I mean, that's something I've had a patient tell me recently, that it sort of feels like there's a third person at their appointments. It's them, it's their doctor, and it's their insurance company. So it's not to suggest, I just want to be clear, we recognize that there's a role for prior authorization and cost containment strategies. But we do see a need for some common sense guardrails to ensure that patients have access to the medically necessary care that they need. And I think from my organization's perspective, this draft is shaping up to do just that. You have a letter from the AMA, and Emily's going to speak more to that, and the Arthritis Foundation. We think it offers some really good suggestions and should be adopted into the model. In particular, we'd really encourage you to adopt their suggestion around data reporting, that it should be on an individual service level and just to make it more understandable and meaningful rather than in aggregate. And then we'd also suggest you consider maybe even going one step further and adding, when you look at the reporting to the insurance department, adding services that are most often approved. You've got a whole list of things that are I think great in that insurance department report, but just adding the things that are most often approved, I think it'll help give you a window into where services, maybe you're getting approved so often that they really don't necessitate prior authorization anymore. So some kind of similar getting at what many states have done with gold carding. I think with that, I'll pause and I'm happy to answer questions. Oh, I should also say, in addition to the kind of many hats I wear at LLS, I'm an NEIC consumer representative. And so we've been having a lot of these conversations with your regulatory partners at the NEIC and in states, and would just really encourage kind of the ongoing partnership that you all are doing. I know NEIC had a white paper come out today, a white paper draft come out today. I haven't read it. I've been here with you all. But, I know it's intended to help regulators, effectively implement and enforce these new laws. So I would just encourage your kind of continued partnership there.
Lucy, thank you
Thank
for
you.
those comments. Next up, we have Emily Carroll from the American Medical Association. Emily, the floor is yours.
Thank you so much. And I had a few slides. Miranda, do you have the clicker down there? Miranda? Sorry. Thanks. Wonderful. Thanks, y'all. Appreciate it. So thank you so much for inviting me back. It's such a pleasure and honor to speak with you again on this important issue of prior authorization. And I think last time I spoke with you, as Lucy mentioned, I presented next to the Arthritis Foundation, Melissa from the Arthritis Foundation, and subsequently we submitted a draft set of redline comments to the bill as is, and I'll walk through those changes in just a minute. Also, since we've been here, or I've been with you last time, there has been some good progress in the form of a voluntary pledge from several of the health insurers to make some of the changes that are included in this bill, including the 90-day grace period when a patient is transitioning plans, improvements in transparency, and some efforts around automation. We're really optimistic about those changes. I'm sure my colleagues from the health plans will speak more to that. But we've also been down a similar road before in the form of the 2018 consensus statement with our colleagues. And I think what was missing from that, because we did not see a lot of results from that consensus statement, was accountability. So I don't think these pledges are a signal for legislators to kind of take their foot off the gas right now in terms of legislation to reform the prior authorization process. I would actually say, not in despite of the pledges, but in light of them, that it's really timely and important for us to consider talking about prior authorization legislation and for states to continue down this road. So I'll walk through just a few of the red line changes we had submitted. The first, I think there is a real opportunity to kind of strengthen some of the provisions to avoid treatment delays. We know that treatment delays result in real patient harm, and states are really moving in this direction in terms of shortening response times, including several states represented here today, and Medicare Part D. Medicare Part D uses a 24-hour deadline for urgent care, and we've seen a couple states do that, and then we've seen a number of other states reduce to around 2 calendar days or something similar for non-urgent care. So we would really suggest that provision be edited in the bill to reflect those timelines. I also think there's, I spoke just a little bit about how there's some efforts around automation, but I think it's really important that we make sure state bills are aligning with the federal rules on automation. There's been actually some great progress at the federal level, and Terry's kind of an expert in this, so I'll let him speak more to this. But I think it's really important that we're not sort of creating another set of rules in the states around automation when so much good stuff is going on at the federal level. And that kind of automation is not exiting any physician's EHR, going to a portal, having a bunch of logins for different plans. It's really about automation through the physician's EHR and being able to complete prior authorization really directly that way. Moving on, I think there are some also opportunities to strengthen the provisions around continuity of care. One of the best ways to ensure that we prevent delays is by preventing repeat prior authorizations. So if you are stable on a treatment, as Lucy just mentioned, the excellent example of having a prior authorization for every chemotherapy appointment, really preventing those repeat prior authorizations protects patients from those disruptions in care. So sections 13 and 14, I think, could really benefit from ensuring that a prior authorization be valid for at least a year or the length of treatment, and that also ensuring that prior authorization should never be repeated for a patient with chronic conditions. Again, we've seen a lot of states move in this direction, as well as some movement at the federal level to prevent these repeat prior authorization requirements. I think there's an opportunity also to reduce inappropriate denials. There is some great language in this bill around a qualified reviewer on the plan side at the point of appeals, but we know that physicians and patients don't always appeal. So I think it's incredibly important to ensure that we have a physician licensed in the state, practicing in that same specialty and with experience treating that disease, making a denial on the plan side at the initial determination level. I'm not talking about approvals, I'm talking about denials. So I think if we could edit the bill to ensure that qualified reviewer at the initial review, we'd make a lot of progress in reducing inappropriate denials initially. And then finally, as Lucy mentioned, making sure that the data provisions in the model bill are ensuring that we're getting as granular and meaningful and usable a data as we possibly can. Right now in the model, the data is being reported at the aggregate level, and we'd like to see that brought down to sort of the individual service level to make sure we're able, and as policymakers, you're able to use that data to really evaluate the impact of prior authorization. Are there certain disease states that are really, bearing too big a burden in terms of prior authorization programs, and where meaningful reforms can be made? So I'll stop there, but I really appreciate the opportunity to speak to you all again and for you all taking up this important issue.
Thank you, Emily. Next, we'll hear from Terry Cunningham from the American Hospital Association. Terry, please.
Thank
Floor
you all
is yours.
so much, and thank you so much for allowing me to come talk to you about this important issue again. Really appreciate the opportunity and excited for some of the work that's ongoing in this space. My plan today is to quickly go over some of the specifics of prior authorization, why we are here, but honestly, Lucy did such a good job, so I'll try to rush through that. I'll also kind of go through some of the things that we're really excited about in this current bill, and then I want to focus on 3 potential improvements that could make this already strong bill a little bit stronger, and then I'll wrap up and hopefully have the opportunity to answer any of your questions. So with prior authorization, it's really a twofold issue that you hear from both providers and patients as to why this is an issue. Really falls into 2 buckets. One is prior authorization can delay and disrupt care. You see some of the information, some of the links I have here, but patients report that prior authorization can be problematic for their accessing care. Physicians indicate that it has a detrimental impact on their patients. And then federal regulators who've looked at the specifics of some of the federally regulated plans have indicated that it's often wrong. They're getting these denials of care that should have been approved as medically necessary. The other area where it's such a problem with prior authorization is there's such a difference in each insurer's way that they approach prior authorization. Whether that be, is something subject to prior authorization? What information do I need to satisfy in order to actually get this prior authorization approved? And how do I send that information to the plan so that they can approve this prior authorization? There's a significant variance, and it's really idiosyncratic depending on the plan as to what is expected. So in this, we were so excited when we saw the NCOIL model legislation come out. And specifically, there's a whole bunch of great things in the bill. I'll call out a couple of things. One is it requires the disclosure and the establishment of the validity of the actual medical criteria that's being used. Plans are required to report what they're using, and these have to be evidence-based and based on nationally recognized guidelines. This prevents some of those inappropriate denials that we talked about earlier. There's heightened time restrictions. As Emily said, I would tend to agree with her that the time restrictions need to be improved, but it's a start. It's looking at the time restrictions. Right now, there is no cap on these in many instances, and so the fact that this bill is looking at it is fantastic. There's also requirements for specifics on denials, as well as continuity of care provisions and restrictions on when a medical necessity provision can actually be revoked. And it also has important enforcement, which again I think is crucial to the success of this type of reform. As I said, there's a couple of areas where I think this committee has an opportunity to tweak their legislation slightly and make real impactful changes that can benefit both patients and providers. The first area I want to talk about, there's a bunch of areas in here, whether it be the electronic standards of care, reporting requirements, insurer review requirements in terms of looking at their prior authorization requirements, as well as the length of approvals. But I do want to focus on the top 3 I've got listed here, which are the post-acute care space, the reviewer credentials, and specifically when a physician with the appropriate level of credentials has to look at care, and then the electronic standard that Emily mentioned earlier. Post-acute care. So this, when I talk about post-acute care, I'm sure everyone's aware, but this is what you're talking about is long-term acute care hospitals, inpatient rehab facilities, skilled nursing facilities, and home health care agencies. This is an area where prior authorization is particularly pronounced and problematic. Part of this is because prior authorization, when you're seeking prior authorization for a post-acute care stay, you're already engaged in an acute care hospital. And what is required at that stage is up-to-date clinical information so that they can approve it. This isn't something you can plan in advance. Your patient has to be at a specific state of recovery or state of being ready for recovery for you to request prior authorization. So at the time you're requesting, all the time it takes is direct delays in them accessing the most appropriate space for them to engage in their rehabilitation. Also, the post-acute care space is a huge space where there's been a high rate of inappropriate denials. This is something that we saw in the U.S. Senate report, which came out of the Homeland Security Permanent Subcommittee on Investigations last year, as well as the HHS Office of the Inspector General report that came out in 2024. It found that post-acute care prior authorizations are frequently inaccurate, and they should have been approved when they're not. And so recommendations I have, honestly, the first recommendation is already covered by this bill. I included here, but I think the bill does a fantastic job of addressing making sure that the appropriate medical necessity criteria are valid and based on appropriate medical terms. It's the second area where I think this bill could be improved, which is because of the specific nature of post-acute care and the reason for when post-acute care authorization is being sought, that patient's already ready to transfer, and every delay is going to delay them from accessing this care. I would argue that, and I recommend that this committee categorizes all of these post-acute care authorizations as categorically urgent and subject to those shortened time frames. This will speed up patients' ability to access that necessary downstream care, and it'll prevent some of these delays from really having detrimental impact on some of these patients' health. The other, and I'll admit, I don't know if reviewer credentials is the appropriate title for this slide, but is looking at when a physician who has the appropriate level of training should be looking at a denial. Currently, what the bill says is it's whenever there's an appeal, there has to be a formally trained medical professional who's reviewing something. And I would argue that actually has to take place whenever there's a denial. Part of that is just looking at the nature of a denial of care. Anytime there's a denial of care, it's a significant disruption in a patient's care plan. Now, it could be appropriate. Again, prior authorization has its place, and there might be times when this should be disrupted. You shouldn't be going down this path. But we do need to recognize if there's a denial of care, it's going to disrupt this patient's care plan. And additionally, it has to take into account the specific individual patient needs and their clinical needs. And so at this stage of the denial is when you need that appropriately trained medical professional. You can't really consider an individual patient needs if you don't know what they mean. And so you're going to be issuing a denial when you might not have the full picture. And you're going to disrupt this patient and expect them to have to undergo appeals process, which can take so much longer than the time frames we have established here to rectify. And so I would recommend that the physicians with the appropriate expertise in the field of medicine actually be required to review all adverse medical decisions, all denials, not just on appeal. The third area I want to cover is the electronic standards, and I brought this same guy in the picture back for this. Currently, there's no standard for how to submit prior authorizations to plans. You've got phone, fax, a transaction that was well-intended but didn't quite necessarily meet the industry need called the ASCX 12278 transaction, as well as portals and websites. And I think this committee did a fantastic job of looking at that situation, saying we need to fix that and make it more electronic and streamlined and helpful. But I want to recommend that proprietary websites and portals might not go far enough. In order to use a proprietary plan website or a portal, you've got to log out of, or remove yourself from your EHR, log into this specific plan portal, extract information from that EHR, download that information, upload it to that plan portal, and submit that for use. You can imagine for the enormous amount of plans with which providers are dealing with, that's still an area where there's going to be a lot of administrative burden. Also, and I'm sure our plan colleagues will be talking about this, this is actually inconsistent with the CMS requirement and the pledge that we just saw, which is that they plan to use an industry standard that applies to all plans that are governed under this, which is to use what's known as the HL7 FHIR, which is Fast Healthcare Interoperability Resources for medical services. And it's basically something that integrates into your EHR, and it allows you to extract information, send it to a health plan so that they can digest it and then review and issue a prior authorization response at that time. That's a much more streamlined, effective, and efficient way of conducting prior authorizations. Similarly, in the prescription drug space, you have a streamlined process known as the NCPDP script standard, which does very similar. It's something that's integrated into your general workflow. You're able to kind of answer some questions as part of your system and move that along to the insurer so that they can determine whether or not the plan should be issued, or the patient should be able to receive the care or drug from that provider. And so I would recommend that this committee consider naming those standards as the appropriate way of creating a streamlined approach to prior authorization. With that, I'm pushing the wrong button, sorry. Just want to note prior authorization is right before them. I'm really excited about this bill, and I think with these updates, we could really make an even more substantial improvement to patient care. I look forward to any questions you might have. Thank you so much.
Thank you, Terry. Next up, we will hear from Randy Chapman with Blue Cross and Blue Shield. The floor is yours.
Good afternoon, Mr. Chairman, and good afternoon to the committee, and thank you very much for the opportunity to speak with you all today. I'm Randy Chapman with the Blue Cross Blue Shield Association, or BCBSA. BCBSA is a national federation of 33 independent, community-based, and locally operated Blue Cross Blue Shield.
My daughter Edna Mae was born.
They cover and serve and support 1 in 3 Americans in every zip code across all 50 states and Puerto Rico. Our plans contract with 96% of hospitals and 95% of doctors across the country and serve those who are covered through Medicare, Medicaid, an employer, or who purchase coverage on their own. We share NCOIL's goal of reducing administrative barriers to care and ensuring that patients receive the right care at the right time. We also believe it's critical that any prior authorization reforms accomplish three things: preserve the ability to reduce inappropriate or duplicative care, promote adherence to evidence-based standards, and ensure that every healthcare dollar is spent wisely. In our recent commitment that our colleagues on the panel here have alluded to on prior authorization and our comments on NCOIL's draft model aim to ensure that this balance is achieved. So I want to talk briefly about the recent industry commitment and provide an overview for you all before I turn to my colleague Miranda Motter with AHIP. So in June of this year, Blue Cross Blue Shield Association, AHIP, and other national insurers announced a series of commitments to simplify prior authorization with a focus on making it faster, more seamless, and more streamlined. This broad pledge that we entered is focused on further improvements to the patient experience and include further reducing the use of in-network prior authorization for certain medical services, fast-tracking responses for electronic prior authorization requests, providing personalized support and more transparency in the prior authorization process, and creating a more seamless process for people who switch health insurance companies. Our goal is to have some of these commitments at least implemented as early as January 1, 2026. Now, even before this announcement, BCBS plans were taking actions to reduce prior authorization. For example, one of our companies removed prior authorization for more than 700 medical services, going beyond the requirements of the state legislation in their state. Another plan implemented an electronic prior authorization tool for pharmacy drugs to reduce time for members to access needed pharmaceutical care. And those are just a couple of examples from many other individual plan examples. In addition, as Emily mentioned, in 2018, the industry participated in building a consensus statement with the provider community. This new commitment moves beyond that and builds upon the ongoing efforts of individual plans, bringing all of those efforts together with consistency and metrics. And I'm now happy to provide additional information, but we'll turn it to my colleague Miranda Motter.
Thank you, Randy. Miranda Motter, the floor is yours.
Thank you. Thank you very much, Chair and members of the committee. Just wanted to thank you for the opportunity to be here this afternoon. Miranda Motter, Senior Vice President of State Affairs and Policy for AHIP. AHIP is the National Trade Association that represents health insurers all across this country, working with you and your constituents as they try to access affordable, high-quality, outcome-based care. So thank you once again for the opportunity to be here. I know I have been here a few times talking about prior authorization, so just really wanted to dovetail the comments that my colleague Randy Chapman made about this important industry initiative that was recently announced. I would echo all of the comments that she made. The other thing that I would say is hopefully included in some of your materials, there is a link to all of the participating plans. So I would encourage each one of you to look at that. The other thing I would say is hopefully in some of the materials that we provided, we also issued an issue brief that does really two things. One, it outlines some new data that AHIP recently released as part of a 2024 survey that looks at things like the number of prior authorizations that are still submitted manually, the number of the percentage of claims for prior authorizations where prior authorization is actually applied to. And I think some of those statistics I mentioned the last time I was here, the percentage of reviews and the annually how plans are reviewing their prior authorizations on services. 100% of plans are doing that. So I would just encourage you to look at some of those updated statistics. And in addition to that, the overlay of the industry initiative relative to the 6 major components and pillars that you'll see in that. Happy to answer any questions as it relates to those things. The other thing that I really wanted to quickly talk about is, and appreciate hopefully some upcoming time. I know I talked to Senator Michelle about sitting down with him and really going through in detail some of the red lines that we will be sharing with this committee at a more fuller level, but really wanted the opportunity to sit down with him first and talk through those things. I would just mention that there are 4 areas, high level, that we will provide red lines on. One is really focusing on strengthening the electronic prior authorization provisions that are included in the model, and I think we've heard from the provider community that these are really important. We continue to see that almost 50% of prior authorizations are submitted by fax and manually. So when you think about the requirements on plans to build these electronic systems, certainly embedded in the model is a requirement on providers that they submit through those electronic systems. But one of the things that we really want to make sure is happening to ensure that provider accountability to get that care to the patient as quick as possible is recommending that providers are able to avail themselves of the faster turnaround times for their patients only if they submit as required in the model. And then also looking at things like, in addition to the reporting on providers to departments of insurance, where there are places where providers are not and consistently not submitting the right information, the complete information that is really important to get that patient care to them quickly, that they're also doing that kind of reporting so that consumers and the public can understand where providers may be falling short. The other area is really around making sure that the model is focused on prior authorization. There are some areas that we see in the model's terminology that it appears to be a little bit broader than prior authorization, and that may be unintentional. And so I will use a phrase from the chair during the last committee. We want to make sure that we keep the main thing in the main thing. And so the second group of recommendations, you'll really see making sure that this is focused on prior authorization. The third area, and again, I know that we heard some of our provider community understanding how important it is to align with some of the federal requirements. We will be making recommendations that the model aligns with the interoperability rules and making sure that that does not apply to prescription drugs. That is one thing that the interoperability rules were very clear. That will be the third area. And then last but not least, there are a series of just what I would call belt and suspenders, technical language changes that we'll offer and talk through with Senator Michelle before we submit those more generally. So with that, just thank you for the opportunity to be here once again.
Thank you, Miranda. Panel, thank you so much for your input and your comments, information. Obviously, we've had this conversation in Charleston, now in Chicago. And so I'll open up right now. We have a question. Go ahead, madam.
Thank you. Representative Dietrich from Wisconsin. And so we're pretty far down the line working on this model legislation. I brought all stakeholders to the table on it because I think it's important to get it right rather than fast. Appreciate what AHIP has done. Here are a couple of our hang-ups on where we're at, and maybe this will be instructive for the model legislation as well. Definition of urgent. That has come up. Like, what parameters are we going to put around defining urgent? I don't know if anyone else has run into that in their state. The other piece is retroactive denials. We've heard this from the physicians, and I know our AHIP representative in Wisconsin was like, that's great, but like, can you get us some examples, because they haven't seen them. So I guess I'd like more information about that, and you know, do we have data that is kind of bearing out that this is a bigger problem right now? Thanks.
Thank you, Representative. Any comment at this point on her couple of questions? Emily?
Just to follow up on those questions, we do have a definition in our model bill of urgent services, so I'm happy to share that with you. We'll do. And on the retroactive denials, we certainly hear from physicians a lot about concern that going through the prior authorization process is not a guarantee of payment. And so, and the harm that it can cause first to the physician practice, but then the patient who has relied also on that approval. In terms of data, I can certainly get you anecdotal stories. I don't know if we have as much data per se as I'd like, but I'll follow up and get you some examples for sure.
Miranda?
I'll just make just a couple of quick comments relative to the definition of urgent. Certainly there are definitions that exist in federal law that I think are really good guidance. The other thing that I would say, at least as I read the current language in the model, I mean, largely how a service is defined lies with the provider. So if the provider deems it urgent, they deem it as urgent. At least that's how I read the language. So, you know, I think, I think there are a couple of places to sort of look at definitions for consistency and uniformity.
Yeah,
That are
I guess
instructive.
what I would give you feedback on is, there's definition difference between emergency and urgent. Is kind of what we're wrestling with in Wisconsin.
Well, and I would say that is a sort of a great case in point to, some of the, what I would call belt and suspenders, just recommendations as we'll walk through those. There are some places, I think, in the model where, terminology isn't used consistently when you think about it from a model perspective, right? Something that may be used all across the country. So the other thing I would just quickly note on retroactive denials, I think you and I had talked about that. Prior authorization approval is not a guarantee of payment, but where we see denials is where the correct codes were not submitted, where a different service was performed. So there are times where that happens. The other thing I would just quickly note, and for those states that have adopted a gold carding legislation, I mean, one of the things that quite honestly we have heard post gold carding legislation is that providers in general are concerned about it and continue to submit prior authorizations despite not having to do that, because for the very reason that they don't want to be at risk for providing a service that is not covered. And so, I would just think about that. Sometimes when we hear the concern about the increases of prior authorization doesn't, align with what our data shows in terms of the number of services that are subjected to prior authorization. Sometimes providers continue to submit prior authorizations despite them being required. So I do think that that's an important note. Is it required, or are providers just doing that just to make sure that they're not at financial risk for a service that they provide?
Okay. We'll follow up. Any questions? Terry, I know you looking to comment there. If you wouldn't mind, Representative Alverson has a question.
Thank you, Mr. Chairman. Great model act. Really appreciate it, Senator. You mentioned the dreaded gold carding word. I was wondering if that was going to come up, Miranda. So I'm gonna, since you brought it up, I'm not going to bring it up. But I appreciate that. But I do want to say to my friends at Blue Cross Blue Shield that I know we did pass that in Texas. And I will say that BCBS of Texas has done a miraculous job of implementing the gold carding bill. And there are, as I heard, which was 2 years ago, there were more than 10,000 physicians in the state of Texas who had received at least one gold card exemption from Blue Cross Blue Shield. So Randy, I just wanted to give you a thumbs up for that. So I wanted to zero in on, to me, one of the most important pieces of this model, and I heard some of you talk about it, has to do with the fact that if you're denying care because your reviewer believes it's not medical necessary, that's the practice of medicine. And so what I see in this model that is reassuring to me, and I think I heard the AMA talk about it, is look, you have to have a physician that reviews these things. And furthermore, that physician has to be licensed. And furthermore, every physician that practices in the United States, there are only two mechanisms by which that individual can be held accountable for their medical decision making. One is through their license, and the other is through medical tort. And I, as a provider, much prefer the former rather than the latter. And so I do think it's really, really important when we say something about, got to have a license to practice medicine somewhere. Not only that, you got to have a license to practice that can actually be held to account when you fall below the standard of care as a provider, denying someone else access to medically appropriate care, because that's medical decision making that you're involved in. You are saying, I do not believe this is medically necessary in my professional opinion. That's medical decision making, and those providers have to be held to account. So I'm just wondering, could any of you comment on that, on the whole idea of, I understand there are limitations, especially when we talk about same specialty, that it can be hard to keep a network of providers in each state that are in each individual specialty that are doing these reviews. But how do we make sure that the providers who are doing the reviews on behalf of the insurers, that their medical license is held to account in the event that they should make medical decisions that are grossly out of line with accepted standards of medical practice? And I'm just wondering if you have any thoughts on that.
Well, first of all, I couldn't agree with you more that making a medical necessity determination, especially denial, is the practice of medicine. I don't know if this answers your question specifically, but in our model bill, we are now requiring that the reviewer on the plan side include with a denial their NPI and information as it relates to their qualifications to make that review. So I think, we've struggled, when states that have passed those provisions on the qualification of the reviewer, we struggled sort of with enforcement in that aspect. And so we've kind of tried to explore ways to enforce that, and that's what we've come up with so far.
Yeah,
I don't know if it goes far enough.
You bring up an interesting question, and I'd love to hear from my friends on the plan side. Notwithstanding tragic recent events that are really, truly horrible, is there ever a role for anonymity in somebody who's essentially involved in denying somebody else access to care if the point is that they be a licensed physician involved in medical decision making? I mean, every prescription I write, every medical chart, I have to sign my name and put my number. And so I just wonder, is there any comment, Miranda or Randy, on what is the limitation of protecting your employees and the privacy and such? But when you're involved in medical decision making, what is the mechanism by which somebody can be held accountable for their medical decision making? Should it fall under scrutiny as maybe this is not the accepted standard practice for this particular thing? They've fallen below the standard of care. If they were actually treating that patient and they fell below the standard of care, a complaint could be filed against their medical license, and they could actually lose their medical license for failing to practice according to the standard, or they could be sued. And so I'm just wondering, what's your thoughts on the balance there? Like, you do realize that's like a important mechanism to be able to hold them accountable, right? So how do we protect them, but at the same time hold them accountable? I guess is my question.
Well, thank you for the question. I keep talking out the wrong one. Thank you for the question. I guess, I have a couple of reactions, and I appreciate that you raised the tragic event that happened, really tragic event that happened last year. And, I think,
shortly thereafter, you did see significant concern, not just from the planned community, but broader community, about, the public sentiment that resulted shortly thereafter. So I think there continues to be concern. I think that there's a way to make sure that there's an awareness about who is making that decision. And I know states and insurance departments, quite frankly, made some decisions and have extended some of those decisions to make sure that is well thought through. There is accountability, certainly through the appeals process. The other thing that I would just say, and this for your own plans, that you all avail yourselves through your state employee program, that the decisions are also made through the lens of coverage, right? What is covered and what is not covered. And so I would just, leave that, I guess, is the last sort of point, just to make sure that is also, taken into consideration as you think about that.
Yeah, I mean, Miranda, respectfully, whether it's a covered benefit or not a covered benefit, obviously is not medical decision-making. But when you're saying it's not medically necessary, that's medical decision-making 100% of the time. No ifs, ands, or buts. So, I mean, I think those two can't really logically be conflated because they're completely separate decision-making processes. I understand that those are the two main reasons why a prior authorization may receive an adverse determination, but they're not one and the same by any stretch of the imagination. One requires advanced medical training. One is basically, what does the manual say? Is this in the plan? Is it not? Is it covered? Is it not? It's pretty straightforward.
I'll leave it at that. It's because there's a lot more great comments. Appreciate that. Terry, you got?
Yeah, I just want to point out, I'm glad Dr. Alverson raised this.
Real quick.
Does this not work? I'm sorry.
You're good.
I'm glad Dr. Alverson raised this. That's actually an issue in the Medicare space. They recently passed requirements of this type of, you have to have the appropriate level of expertise, but it's a complaint we've heard from our providers is, how do I know that the person reviewing, if they're not going to sign their name or put their, something like a taxonomy code at least or something, how do I know that that lack of transparency breeds the lack of trust that it actually took place? And so I do think it's an important thing to consider, whether it be identifying, providing a taxonomy code, what it exactly looks like. I do particularly like the AMA's language that they have in their model bill and things such as that. But I do think it's an important issue, and I'm glad it was raised.
Totally agree. Representative Alverson, great question, great dialogue. You guys can obviously follow up on that. That's a big time question. Senator Michelle, any closing comments, any questions whatsoever at this point? I anticipate an interim get-together again between now and Atlanta. Again, we've talked about this in Charleston, now Chicago. We need to, I think overall, I don't want to rush Representative anything, in particular this prior authorization. This is super important. It really, really is. We want to try to get this as close as we can to being perfect as we can. So great questions, and I'll appreciate that so much. If you have any other questions, please reach out to NCOIL, Senator Michelle, anything like that. But again, anticipate that interim call coming up, okay? Probably around September, October. Thank you all so much. Next on our agenda is a presentation from an organization called Every Child a Swimmer. Interesting. But I've used that word quite a bit today. We're joined by Casey McGovern. Hi, Casey. Welcome to the panel here. She is driven by a personal mission to prevent child drownings. I don't want to take anything away from her remarks. So, Casey, the floor is yours.
Thank you so much. I believe that we're going to start with a video, if you don't mind.
My daughter Edna Mae was born December 29, 2007. And she was truly the greatest gift to our family at that time. It was our first major loss. My mom was. So having a brand new baby was like new life. And she really was. She just kind of came into our family unit and just blessed us. The day of M's incident, what's so fascinating is the pool wasn't even on my radar. I didn't even look at the pool when I went out. I remember walking past my pool. That's when I caught the glimpse of him floating in our pool. And to this day, I have that vision. I have that vision of her floating, exactly where she was floating, in her white dress that had polka dots that my sister just bought her maybe 2 weeks before, and her bright blue eyes looking right up. And I ran over screaming, grabbed her, and yelled to God, help me, help me. When an incident like this happens, many, many, many lives are affected by each one of these tragedies. And I felt like the nursing staff and the doctors there took care of our family just as much as they were taking care of her. They worked to educate us. They allowed at one point, when they changed her bedding, for me to hold her in a rocking chair and just love on her. They allowed me to brush her teeth and care for her in any way that I could. And as a mother, you just want to comfort them. You just want to make it better. And I couldn't make it better. And then I had to let her go. And so I told her it was okay. I took her earrings out of her ears. I placed them in mine. I clipped her little lockets, the little bit of hair she had, and made her promise that I would fight to prevent this from happening to anybody else. I'm going to make this my life's mission to stop this from happening. My name is Casey McGovern, and I lost a child to drowning.
Good afternoon. I just really first wanted to start off by saying thank you. Thank you for allowing me to come and tell my story in the hopes of saving many other children. Like they said, my name is Casey McGovern, and I have been at this work for 16 years. I am now the executive director of the Every Child a Swimmer program that provides Learn to Swim scholarships to the underserved population, and we also advocate for legislation throughout the country. And I'm here specifically today to ask for your help. I think that this is something that we need to make a national kind of approach, and education is absolutely the key. So I'm going to run through the slides. If I could hit the next one. The clicker's not working. The green one? Okay, sorry about that. All right, so just to reiterate, my daughter's incident happened on August 3rd. I left her on August 10th. During that week, I learned how big of a problem drowning really, truly is. And upon leaving her, I made her promise that I would do everything in my power to educate as many families as I could about the issue. And from that point, I haven't stopped. I worked for the Florida Department of Health for 8 years, running the drowning prevention program, where I learned and I healed and met a lot of great people, and also the approach of preventative work. This is 100% preventable, and so that's why I'm here doing what I'm doing. What is the Every Child a Swimmer program? Again, it's a national initiative from the International Swimming Hall of Fame, and we provide Learn to Swim scholarships to those that cannot afford it. We give them 3 months of swim lessons to ensure that they will never fall victim to being, falling victim to a drowning. We strongly vet our swim schools, and we have currently about 362 swim schools that we're working with. We really have high standards. Last year, we awarded $632,000, impacting over 3,000 children throughout the United States with the Learn to Swim scholarship program. But that is not why I'm here. I'm here more so for the legislative efforts, the touch point with the parents, allowing them to understand that drowning does not have to happen to them, and that this is what you need to do to prevent it. I just felt like this was important because this is another way that we combat this issue. So why does this matter to you? Because drowning is the #1 cause of death across the board for children 1 to 4. It's the #2 cause of death for children 5 to 14. And we lose approximately 4,000 individuals each and every day. CDC reports that for every 1 fatality, 8 children or people are impacted by a non-fatal injury, which means they were submerged, needing to have CPR, and they were also hospitalized. So when you look at those numbers are incredibly large as far as just the victims being impacted by something that's preventable, but also $10 billion fiscally is caused by something that's preventable. So I feel like it's important for me to kind of break down those numbers a little bit, because since my daughter's death, 64,000 children lost their lives to something preventable. If you want to think about it in that context, 64,000 people have been uprooted and something taken away from them and will never be the same. But if you look at it on a fiscal aspect, $160 billion was caused because of something that we could have done to prevent it. So we're talking about preventative work, we're talking about those touch points, those layers of protection, and educating families about it. When I lost my daughter, I thought that only happened to those type of people. That could never happen to me. I had the fence. My daughter was 19 months of age. She was much too young to learn how to swim. So I had all of these stigmas in my head that only happened to those type of people. And now I want to normalize that since my daughter's death, August 3rd will be 16 years, I've met thousands of families that are just like me. And they're telling the same story. I just didn't know. And this legislation is something that could really, truly make an impact. I know that this is small print, but this is available. I could send it to you, but I also think it's through the NCOIL piece. But the ripple effect. My daughter passed away, which obviously uprooted our entire family. Her siblings, my husband, our immediate family, my parents, aunts, uncles, cousins, neighbors, our church friends, the schools that our other children went to, first responders, healthcare professionals. You don't realize the ripple effect of change, but I am still incredibly close with the PICU nurse that took care of my daughter for a week. I'm still incredibly close with the first responder that came and did CPR to my daughter while we were sitting in our backyard trying to save her. I'm incredibly close to them. And one of the first responders, Candace Oltz, said to me, enough of these situations are like rocks in their pocket, which cause mental illness and suicide rates with the first responders. And so, you don't think about it just impacting my family, but you have to think about it as a ripple effect that's causing horrible tragedies with other people because of something that's preventable. And so we have had success passing this legislation. What it requires is all schools share water safety information with parents and caregivers at the start of school. My thought with this model is everybody discusses fire safety in the month of October. We all know stop, drop, and roll. We all know we have to have smoke detectors in our home. We know that we have to replace those batteries annually. Why? Because it's ingrained in our brain at an early stage throughout the school system. But yet nobody is talking about water safety. Nobody is discussing it. Nobody's discussing that this claims more lives than most other issues out there. And so we need everybody to come together and discuss it. So the legislation that we had success passing was Florida, Georgia, Arkansas. This year we actually had success in Arizona, New Mexico, and New York. I'm asking all of you to just help us continue this ripple effect of goodness and hope so that we're continuing to make change. Can't bring my daughter back, but we have the potential of saving a lot of other lives by blanketing the United States with this life-saving piece of legislation. There is no fiscal impact, and it's bipartisan. We provide the toolkit necessary for the work to be done. We just need the doors to be open and the help to be able to get into the additional states to share this life-saving work. We have talking points here. I also have these take-homes or these takeaways that has also the talking points in the piece of legislation. The legislation I provided here on the right side, which is hard to read from here, but is from Georgia, and everybody's able to tweak it to fit their state exactly what they want. But in essence, what it does is it provides mandates that all schools share water safety informational resources. Doesn't impact the curriculum, so the teachers union won't push back. Just share this risk factors and where to go for local swim lessons, which we provide the toolkit and help with the implementation. Again, this is just to reiterate the need for it. It is the number one cause of death. It is preventable, and we can do this. But I think that has to be that consistent message that's going out there to say, hey, this is what we have to do to prevent it and normalize that conversation. My contact information is here. Again, I just implore all of you guys to adopt this, help me get in the door, sponsor it, connect us so that we can make this legislation be unified, consistent throughout the entire country, and make every child a swimmer. We do have help with the Learn to Swim scholarships as well as this legislation, but it's the first step. It's the layers of protection. It's the way that we are able to do that to get the message heard to the parents in this factor. But thank you so very much.
Casey, thank you for sharing your story. We had a little 5-year-old boy last week drown in Kentucky. And my first question is, how do I bring this to Kentucky? And you and I will talk after this is over.
Absolutely. Thank you. Thank you.
Any other questions from anybody on the committee? Folks, this is her information. She shared us her why. This changes lives. This can change and save somebody's life. Thank you for being here today. Yes, got a question right here, Representative.
Yes, I do notice my name is Eric DeLon. I'm a legislator from the state of New York. I noticed that it already is law in New York, but I just wanted to let you know personally, as everybody can see, is not more powerful than a mom on a mission. But there is legislative items in New York on top of the legislation that go to communities that teach kids to swim. So we further that effort since that bill's passed, and I just wanted to let you know that.
Yeah, thank you so much. I went there for Lobby Day and also to testify, working closely with the New York Water Safety Coalition. I'm on their board. So anything that I can do, I know that one of the oppositions we had was just the implementation, so many questions. And what we do is we provide the toolkit to make it as easy as possible so that the children get served. One part is educating them about the risk factors, and if they can't get swim lessons, at least they'll know to get layers of protection, as far as that goes. But there's a lot of help out there and a lot of resources. We just need to now pull them together so that we're working together instead of in silos. And I think that that's going to be approached. But thank you so much.
Any other questions, comments? Casey, thank you so much. Please don't leave. Once this is over, I want to talk to you.
Absolutely. I'll be just in the back, and I do have pamphlets here if anybody wants them, but thank you.
Thank you. Our last item on our agenda today is a presentation on the hospital charity care and medical debt. Folks, hang in there with us. I know we're going a little over, but it's good stuff here today. When we use the phrase hospital charity care, we're referring to free or discounted medical services provided by hospitals to patients who might meet certain income or hardship criteria. And this topic was brought forward by our immediate past president, Texas Representative Tom Alverson. And the charity care conversation is really part of a larger conversation surrounding issues with medical debt in the U.S., which we all know is a huge, huge problem. Before we go any further with this discussion, Representative Alverson, share some comments, brief remarks.
Thank you, Mr. Chairman. In the interest of time, I'm not going to say a whole lot other than just to say House Bill 3708 is one of those bills you file and kind of like, oh, it sort of sounds like a good idea, and then you finally have a hearing on it. And I think the whole Capitol was buzzing about it, just blew everybody away. It is shocking to me that in my home state of Texas that according to the Hospital Association themselves, there's statistically no difference in the percent of charity care performed by hospitals receiving hundreds of millions of dollars of tax exemptions and those that are for-profit. Despite that being the reason why charity care exists is for the tax write-off. And I'm not going to take any more time away from these gentlemen, but it just literally blew everybody's hair back when they heard it. They were just like, couldn't believe it.
Thank you. What was that Texas House number?
I think it's House Bill 3708.
3708.
It might actually be in your packet.
Okay.
Yeah.
Is it? It's on the website? Good deal. Good deal. You can view that bill on page 104, didn't read my notes here, in our binders and on the website and app. I would also like to point out that Representative Bennett from Oklahoma sponsored a bill in this state that would prohibit creditors and debt collectors from reporting to any consumer reporting agencies medical debt obtained from life-saving and emergency care services. That bill may also be viewed on page 104 in your binder. I just want to make a note that I'm very interested in this discussion. I would be happy to work with Representative Alverson in this committee. Perhaps mesh these two issues together and develop model legislation. First, we will hear from Tanner Olive, a visiting research fellow with the Paragon Health Institute. Tanner,
thank
floor
you.
is yours.
Awesome. Hello, everyone. So I'd like to thank NCOIL for allowing me to come out here and give me the opportunity to talk and regale you all with I would say regale you with a lesson from Texas, why pursuing charity care shouldn't end with a collection notice, which is a cheeky title, but really this is a presentation meant to kind of articulate the lessons, stories, and evidence found throughout Dr. Oliverson's pursuit of HB 3708 in Texas. So without further ado, also before I begin, Nicholas Armstrong is also on there. He is a policy analyst from the Texas Public Policy Foundation. He was pivotal and helped me with this presentation and was a formidable ally and also a great institution that dug into a lot of the numbers that are used right now. So some lawmakers probably know what charity care is. Some do not. So just make sure we're all on the same page. Just wanted to provide a little bit of context. So when a hospital incorporates as a 501c3 with the IRS, that hospital virtually pays no taxes. Property, sales, corporate income, ad valorem, capital gains, so on and so forth. The estimated tax value that state and federal governments annually forego is between $22 to $27 billion. That's with a B. That's coming from institutions like the Kaiser Family Foundation, Johns Hopkins, Loan Institute, the Baker Institute, and I believe AHA is the odd man out, putting out about $12.9 billion, and I'd love to hear if they have a newly updated number. But going forward from there, state and federal governments allow for this generous tax advantage because nonprofit hospitals essentially have entered into a social contract, right? They're agreeing so the state and federal government saying, okay, you will not pay taxes so long as you take that tax-spared revenue and reinvest it back into your communities. And that's what's expected out of them. And so that's where community benefit comes in, which unfortunately is a pretty ambiguous term if you were to ask the GAO right now, looking at a 22 report. But when we look at 501R regulation with the IRS, some activities that hospitals engage in that could constitute community benefit revolve around doing research, so sustaining cost, training healthcare professionals. So if there's a teaching hospital that provides a residency program, the GME cost is sometimes factored in, as well if you want to train undergrad nurses, public health awareness programs, community building programs, losses from government means tests like Medicaid, and most importantly, charity care. And charity care explicitly, which is also known as financial assistance, is where a hospital covers the entire cost or heavily discounts the cost of care for an uninsured or underinsured patient that typically earns 150% to 400% the federal poverty level. So, Dr. Oliverson's inspiration for HB 3708 did not come out of thin air. There has been a series of scandals, mishaps, or interesting stories that have been coming out of, let's just say shenanigans that some of the nonprofit hospitals have been up to the last 10 or 5 so years. So for the sake of time, I'm only going to cover 2 of them. I'm going to start back because I was born in Washington State and actually know Bobby Ferguson pretty well. And so back in 2018 and 2019, Attorney General Bob Ferguson found that 9 Providence Health and 5 Swedish hospitals wrongfully sent 100,000 low-income patients who were eligible for both Providence and Swedish's own handwritten charity care policies to debt collections. Providence was eventually forced, I think about 2022 or 2023 was when the suit was settled, but they had to cough up $157.8 million in debt relief. And another thing that was interesting that happened during discovery while this case was going on was that there was a document recovered showing affiliation between Providence leadership and Deloitte, who created a program called RevUp. And RevUp was designed to essentially teach billing staff and some other people in the hospital how to mitigate liability for having to disclose charity care policy and the application process to patients. Moving past that, I'd also like to point out what happened in this one's another AHA member, I believe. Yeah, Lena Health, Minnesota. This is happening in kind of between Minnesota and Wisconsin because they're going over the state border. But Lena Health had an internal, this came out from a New York Times investigation, but Lena Health had an internal policy of denying patients care if they had more than $4,500 in medical debt, regardless of your income per year. And also they locked your EHR because why not? hospital administrators would also just would bar you from making future appointments as well, so it was retroactive and proactive. And when asked for comment, Alena Health responded by saying, well, we serve 12,000 out of 2 million patients with charity care per year. That's the equivalent of saying that we serve 0.006% of patients per year, just for if you're not a statistician. So looking past this, we started to a lot of this became motivation for us to dig into what's going, and thinking through what's going on in Texas, because we have some very large nonprofit hospital systems. So I would like to point out, even before session kicked off, there was a desire in the legislature to commission a audit or a charity care performance, if you will, with Myers and Stouffer, which we spent $5 million on. And some of I gotta say, it was harrowing. We had there was actually, I believe I'm reading the statement verbatim here, is that Myers and Stouffer confirmed with HHSC, which is the Texas Health Agency, that there is nothing in state statute or regulation that essentially creates a monitoring, reviewing, or auditing process to ensure that there's compliance with disclosure requirements or calculations for your charity care reporting. So that was an interesting bit out of Myers and Stouffer. So not a lot of oversight there. And then something that also that was kind of odd was when we talked about disclosure, because if you look down below there, you'll see TPPF did a poll showing 87% of Texans were unaware of charity care. That number is most likely consequential because when we did our own legal review, we found out that Texas hospitals of all sizes just have to run one print newspaper ad per year and put signs in their lobby to inform patients about charity care. And the polling, I want to point out too, because we initially ran some polls and it was coming back at 60% of people didn't know what charity care was, but I didn't really believe that 40% of people knew based on this evidence I was seeing. And so we ran a counter poll where we initially asked, do you know what charity care is? And the second question is, can you define what charity care is for us? And that's where we get the 87% number consistently, is because a lot of people mistake when the hospitals issue you a credit card with a high APR as financial assistance, or when they decide to stretch out your payment plan as well. So there's a little bit of it seems like not a lot of patients have the opportunity to or get taught what is charity care versus what's just a way to cover right then and there. So, and the last thing too is that the bar graph we're looking at here too, this was also research done by the Texas Public Policy Foundation. And it's showing that there's only a 1.67 difference in charity care spending between for-profit and nonprofit hospitals. And if you look there, that blue column is showing charity care to net patient revenue when supplemental payments and other programs are essentially money being given to hospitals to provide charity care is there. And when you take that away, which is now where you look at the orange version, you see a very small difference between nonprofit hospitals and for-profit hospital giving. That is insane. We have Ascension, we have Baylor Scott and White, we have HCA, all in our state. HCA probably pays near $1 billion in taxes, wouldn't be surprised. And yet, they're giving almost the same amount of charity care as some of the biggest nonprofits in our state. It is concerning. And so this is where, when we started seeing some of this information, that's when the conversation about creating language came together. And what ended up happening with the final product with HB 3708 was essentially what the bill does, it requires a non-disproportionate share hospital. So think of large metropolitan hospitals, not rural hospitals, and made sure they have their own problems. They don't need to be impacted by this. But they need to pre-screen patients for charity care eligibility before being allowed to send said patients to debt collectors. And this was because the idea process was, well, not a lot of people know this. There's too much gameability going on, so why don't we put the impetus on the hospital to tell the patient about charity care and see if they can apply, opposed to the patient having to just, I don't know, run into a sign in the lobby, I suppose. And the other big part of this bill, it created a penalty process because there was no recourse for if someone was going on day 120 without an answer, if they had their charity care app in. They're getting hounded by debt collectors when their applications are in. They're getting, actually a lot of times they get sued by the nonprofit hospital in question. So we realized that we needed to kind of create an appeals process per se to give a chance. So if a patient is not being treated fairly in this process, or if they're being extended amount of time, or if there's just a complaint, they will now be sending it to HHSC, who will review that And if there's any fault found of this the statute or the language, I should say, that's what triggers a three-part penalty process. The first penalty for being in violation of the bill would essentially trigger a warning, and the hospital would have to essentially create a reconciliation plan, and they'd have to follow through with it, and that they have about 90 days to put that into implementation. If there's a second violation found, they're charged $500,000. If there's a third violation found, we task the Attorney General of Texas to go after those nonprofit hospitals in questions to remove them their tax exemption, because clearly they want to be a for-profit more than a nonprofit. And I think I could sit here and prattle on about what really HB 3708 was about, but there was a conversation had with one of Dr. Oliverson's colleagues, Representative James Frank, with the Texas Hospital Association CEO. And I think this is the kind of conversation you should all go back to your legislatures and try to have, because if it looks like anything in this video, you should be really concerned. Let's see if it plays.
Operate kind of the same. You have to take all comers if you're a hospital. So the charity work of a not-for-profit doesn't seem significantly different than a for-profit. I'm wondering, what is it, if not this bill, what is it that y'all are doing that for-profit hospitals aren't doing, because other than paying a lot of taxes?
Well, I mean, if you're big in Medicare and Medicaid, both of those payers underpay, so there's
Right,
a shortfall.
but a for-profit hospital operates in the same arena.
Correct.
So there is no difference. I ask, what's the difference between where a not-for-profit, what does a not-for-profit hospital do for its not-for-profit status that a for-profit hospital doesn't do? Because the reports that I've seen show that it pretty much is the same.
Correct. Sorry.
Okay, so it's correct. So what's the point of having a not-for-profit hospital if they don't operate any different than a for-profit hospital?
I mean, there's a whole variety of reasons. It's mainly the tax status that has an implication on bonds and otherwise. So
Okay, so basically, I mean, you're the head of THA, and you're telling me really that for-profit hospitals, not-for-profit hospitals, that's kind of crazy. I mean, honestly, you just said the not-for-profit that's not paying taxes, that basically pushing their tax burden to every other member of the community, is doing the exact same thing as an investor-owned hospital. That's kind of enlightening.
We did not play bias in the clip there. He did later confer and kind of explain like how they're giving, but I don't think he recognized what Chairman Frank was actually trying to ask. And I guess I want to just conclude on this kind of notes. Right, we just went through the one big beautiful bill, and states are going to be feeling a lot of pressure and wondering how they're going to kind of readjust to some of the losses they're taking from Medicaid supplemental payments in other arenas. I want to point out that Medicaid is not an insurance of first resort; it's last resort. And actually, nonprofit hospitals, when they decide to incorporate as such, are essentially entering into the public. They're agreeing to enter and be a part of the public safety net, and they are the first line of defense, and they should be issue based. And so with that being said, with great tax exemptions comes a great responsibility. And if you enter into a social contract, you need to understand that tax exemptions are not a right, they're not an expectation, they're a privilege, and you need to show over and over and over again that you're worthy of such a privilege in any state. And that's my time. Thank you so much for having me here, by the way.
Thank you, Tanner. Thank you for your comments. Aaron Wislowski, Vice President of the American Hospital Association, floor is yours. Yes.
Great. Thank you for having me. Aaron Wozlowski, the Vice President for Research Strategy at the American Hospital Association. So what I want to do today is really try to put financial assistance in sort of the broader context, the broader policy landscape, and kind of talk through some of the other considerations that hospitals are kind of working through in addition to financial assistance. The first thing that I want to stress is that from the hospital perspective, the focus on the need for financial assistance or charity care really kind of highlights deeper problems around things like coverage gaps and underinsurance. We see the need for financial assistance as a symptom of a broader problem as opposed to the root cause. Hospitals are not able to sort of fix that broader problem independently. And we see the solution here is strengthening access to affordable, continuous coverage. The last point I'll make, and I'll come back to this, is, and Tanner touched on this, but financial assistance is one component of a broader community benefit. And those community benefits are things that not-for-profit or tax-exempt hospitals report on to the IRS. And I'll talk through that in a little bit more detail. That first point around access to coverage, did want to just sort of lay the framework about sort of trends we expect in the coming years. We've had in the last few years sort of record levels of insurance rates, low uninsurance rates. We expect to see large increases over the next decade in the number of uninsured. The Congressional Budget Office has projected that the impacts of the One Big Beautiful Bill Act will likely result in nearly 12 million people rolling off of Medicaid in the next decade. Not all of those folks become uninsured. Some of those folks are going to wind up with other forms of coverage, but we're still likely to see nearly 8 million people newly uninsured. And those uninsured folks are likely going to result in uncompensated care in hospitals, showing up in hospitals and requiring care and not having coverage. Those cuts, those reductions in coverage are sort of related to $1 trillion in cuts to the Medicaid program in that bill. Those cuts are going to be felt across the board, all types of communities and providers. Certain providers are going to feel those, and certain communities are going to feel those more acutely. Sort of baseline, nearly half of rural hospitals already operate at a loss, so any additional cuts are going to threaten access to care in those communities. And specifically, we've projected that of the 7.8 million people losing insurance entirely, nearly 2 million of those reside in rural communities. So certain communities are likely going to see more need for financial assistance in the years to come. So I just wanted to sort of lay that groundwork. In addition to issues with the uninsured and uncompensated care, and Tanner mentioned this as well, we also see patients with coverage running into challenges, and this often has to do with plan design, things like high deductibles, but also things like plan denials, which can interrupt access to care. And over the recent years, we've seen hospitals increasingly seeing uncompensated care and providing financial assistance to patients with insurance, but who are underinsured, who are in high deductible health plans or in skinny plans. So ultimately, this has kind of resulted in a gradual shift from insurance bearing the risk to providers increasingly sort of bearing the risk of patients, both with insurance and without. So one sort of practical approach that we wanted to focus on here is just sort of talking through streamlining the process for financial assistance. I think everyone would agree that processes around financial assistance can be challenging for everyone involved, fragmented, manual, lots of missed connections and delays. Both patients and providers face challenges and barriers in terms of providing financial assistance, and oftentimes it's not necessarily the fault of anyone in the process, because those processes can be so manual. Providing information, collecting information can be challenging. There's a lot of places where the process can break down. So what we'd like to see is a focus on supporting the modernization of those processes around applying for financial assistance. Things like data sharing, eligibility infrastructure. We've seen increasingly hospitals adopt presumptive eligibility processes where they run eligibility up front. The issue with that we've encountered with our members is that to accomplish that, to be able to run eligibility for financial assistance up front, to try to take the patient out of that process requires, depending on data, that you can determine eligibility. So you need access to income data, employment data, that sort of thing. There are third-party solutions out there that support that. They're very expensive. So hospitals that have opted to sort of go down that road are incurring the expenses of trying to get those data. So the AHA is doing what it can to support hospitals that are implementing those processes, putting together presumptive eligibility resources. Ultimately, though, we do want to note that when thinking about financial assistance and policies around it, when expanding any mandates, doing that without sort of also expanding support for the process of actually applying for financial assistance can just put additional strain on the whole process. The other point that I wanted to make, and I mentioned this up front, and again Tanner touched on this, is to take a comprehensive view of community benefit, of which financial assistance is a part. We spent a lot of time going through Schedule H filings, the filings that hospitals are required, not-for-profit hospitals are required to file with the IRS. When we tally up all of the things that hospitals are required to report on in terms of benefits that they provide to the communities in those Schedule H's, it comes to the most recent look at it we did was $129 billion. We also look at, because the AHA is focused on federal policy, we look at the value of federal tax exemption, and found that that's about a 10-to-1 ratio. When others have looked at state and local tax exemption, it increases that tax exemption value, but the benefits to communities that are reported in Schedule H still far outweigh total tax exemption, no matter how you slice it. But again, coming back to this point of financial assistance is incredibly important, but it is only one component of the benefits that hospitals report on in the Schedule H. We also see that financial assistance can vary widely hospital to hospital, and it's dependent on a lot of other factors. It's dependent on the populations that hospitals serve, the communities they serve. We also see a direct inverse relationship between the amount of financial assistance hospitals provide and the Medicaid shortfall they provide. So as one goes up, the other goes down. That's the case hospital to hospital. We see that state to state. So states that have higher Medicaid enrollment rates tend to have higher Medicaid shortfalls across hospitals and also lower financial assistance. The reverse is true. Looking at different types of hospitals, children's hospitals, for instance, most kids have access to some form of insurance, whether it's Medicaid, CHIP, or private insurance. So children's hospitals end up having very low levels of financial assistance. They have very high Medicaid shortfall numbers. So looking at financial assistance alone is not going to tell you what the value that children's hospital brings to its community or the population it serves. Similarly with critical access hospitals, so hospitals serving remote rural communities, they typically have low levels of financial assistance and Medicaid shortfall relative to other hospitals, but they have very high levels of subsidized services, which are reported in the Schedule H. Those are services where they incur a loss across all payers, so things like emergency services, behavioral health services. So again, looking at one metric like financial assistance doesn't tell you all of the ways that hospital benefits that community. It's a metric, but it's not the only metric. You have to look at the totality of the benefits that hospitals are providing, and the needs of those communities are going to, and the populations they serve, are going to drive the benefits that those hospitals end up providing. So in terms of thinking through policy on this topic, what we'd like to see is a focus on, again, improving access to affordable coverage, supporting hospitals that are pursuing presumptive eligibility to help build out systems that can improve that eligibility process, and also leverage state resources. So in a lot of cases, there are state data sets that hospitals could tap into to help determine eligibility, SNAP eligibility systems or other income eligibility systems, making those available to hospitals who want to determine eligibility. Right now, they're sort of locked out of those systems in a lot of cases. So making that process easier, and then again, recognizing the full spectrum of benefits to communities that hospitals provide. And just to close this out, again, just in terms of thinking about pursuing policy at the state level on this, I just wanted to tee up a few questions to consider when looking at that policy. Does it reduce the need for financial assistance? Does it proactively assist hospitals in assessing eligibility for financial assistance? Does it inadvertently change the scope of financial assistance by expanding it to other non-hospital settings, which could create a non-level playing field? And then finally, does it recognize that determining eligibility for financial assistance based on the way it's currently structured can be complicated for reasons beyond the control of the hospital? Those processes are very manual, so recognizing that that's the reality that we deal in now. So with that, thank you, Mr. Chairman.
Thank you, Aaron. Lucy, you have a quick comment, real quick?
I'll be really fast,
Real
I
quick.
promise.
Okay, thank you.
Lucy Culp again with the Leukemia and Lymphoma Society. I just wanted to comment quickly that it probably won't come as a surprise that about half of cancer patients incur medical debt, right? And actually 42% lose their entire life savings within 2 years.
Yeah.
So this is a incredibly high priority for my organization. We've been involved in laws in states across the country, probably worked with many of you and your colleagues already, and we have model legislation. We'd be happy to partner on this. And, I'll just say, too, there are two pieces to this, right? There's preventing debt in the first place, and it's some of the things you've already talked about, but there's also protecting patients who've already incurred it, and we, really want to see legislation that responds to both things. So just happy to partner and really glad you all are talking about this.
Thank you for those comments. Thank you. Panel, thank you so much. Any questions whatsoever? Yes, ma'am.
Thank you both for this. This subject is near and dear to me. I live about an hour north of here, and I have a for-profit hospital that is doing a tremendous amount of charity care. Individuals, they simply cannot afford to pay for anything. They just show up. They don't have health insurance because the rates are just out of this world. So their health insurance is lapped. They don't qualify for Medicaid, Medicare, or anything else. So they keep going to the hospital. The hospital, of course, takes care of them, but then you have these large numbers of individuals who simply cannot pay their bills. So I'm like in a crux 22 here because you want to make sure these individuals are getting services, but at the same time, I cannot afford to lose my hospital. So what are some things that we can do? Because again, this is for profit, so they are paying taxes, they're paying huge water bills, electric bills, and everything else. They are contributing to the community, but they're at a point to where they may have to close. And how do I keep them open? Well, what are my options?
Doesn't Illinois have con laws? That kind of stops
the state
building.
is broke.
Yeah.
Let me start with that. The state
Okay.
is broke. Okay, so I'm trying to think outside of the box. What options truly are available when you have a for-profit organization? Because most of the state's dollars go to our safety net hospitals, to those that are nonprofits. For-profits are pretty much out of luck. They're like, well, you're for-profit, you should be able to, set your rates and be sustainable. But if you're in a community such as mine, where the majority of the individuals who come to your hospital can't afford to pay for the services that you're providing, what do you then do? When the state is saying, sorry, you don't fit into our niche. You're a round peg and this is a square hole. You don't fit, so we cannot give you those safety net dollars. We cannot increase your assessments in any way. We can't give you any help to pay for all of this charity care that you are required by law to do, and at the same time, we need you to keep your door open.
So I don't have an easy answer for you on that, but I think the heart of the issue that you're describing is that there are real coverage issues in that community. So I think understanding that you can't wave a magic wand, but I think in that case, ensuring that folks have access to coverage is really ultimately the way to solve that problem. I don't have an easy fix for that particular scenario, but
And so if you got any other thoughts, we're way past time here. We got somebody else coming in.
Sorry.
Have that conversation. No, great question.
I just want to keep my hospital open. So
Yeah,
just
absolutely. It's a great question. Continue that discussion right after we adjourn here. Dr. Alverson, you have any last comments?
Yes, Mr. Chairman, just very, very briefly, just yes or no, the three panelists. If you are a healthcare facility that is receiving tax exemptions in exchange for providing charity care, should you have to screen the people coming through your door to see if they're eligible for charity care? Yes or no?
Yes.
Yes.
The AHA deals at sort of the federal policy level, so I can't speak to state-specific requirements. So it's not something that I can provide an easy yes or no answer to.
Okay.
He's abstained. He's
abstaining. Okay. So I asked the question, Mr. Chairman, because that's essentially all the bill does. It just says that if you're getting the tax exemption, you need to screen for charity care, because after all, that's the reason you're getting the tax exemption. Thank you.
Love the bill. Love this conversation and discussion, and we'll continue this on. Representative Alverson, thank you all so much. Wow. Great committee meeting this today. Next minute here, bylaws committee is going to meet right here. Women, you've got a reception here in about 15 minutes upstairs in the 3rd floor, the Urban Blue. 5 o'clock. This meeting is adjourned.